name's Bill Hinckley. I know a lot of you guys, but for those that I don't know, like most of you, I'm desperately in need of a haircut. I'm pinch hitting today. I'd like to thank my friend, Dr. Lubbers, for inviting me. He neglected to tell me that I had to follow Christofelli, though, so I'm regretting this decision a little bit. But I want to talk about HEMS, helicopter EMS, scene response for stroke and STEMI in the rural setting. Is it always awesome? Is it always a good idea? I grew up rural. A lot of you don't know that. And most of my friends as a kid were Amish, actually. So I'm very much a hick. And the optimal care of rural stroke and STEMI patients is therefore something that means a lot to me. Let me figure out my slide advancer. So I'm an ER doc. And I'm a flight doc. So I have the fairly unique position of often in the same week, I may be the referring doc for an inter-hospital helicopter EMS flight. I may be the accepting doc at the ivory tower. And I may also be the flight doc who actually does the transfer all in the same week because I work in many different settings. I've been a flight doc for a long time now, apparently since even before Nomex was invented. I believe this is my 19th year doing this. I'm one of the few people that have flown on all 4 of these airframes that AirCare has had over the years here in Cincinnati. On the left there, you've got the BO-105 all the way up to the black and red EC-145 that we fly in now. I've flown in all of them. I'll take the 145 any day though. So stroke and STEMI. Pathophysiologically, obviously, we're talking about a plumbing problem. And it's not a whole lot more complex than that, at least at the level that we need to understand it. We've got a clog in the plumbing somewhere. And downstream from that, we've got neurons or myocytes that are dying by the millions each minute that perfusion is not restored. So in terms of treatment, basically, we need either liquid plumber or we need a drain snake. So liquid plumber, I think of as sort of akin to fibrinolysis or TPA. And the drain snake, I think of as fairly akin to PCI, percutaneous coronary intervention, AKA angioplasty and stenting for a STEMI, and fairly akin to embolectomy for a large vessel occlusion ischemic stroke. And this is all about time, very much like trauma. There is a plethora of literature showing just how time dependent patients' outcomes are when you're talking about a true ST elevation myocardial infarction or an ischemic stroke. Now, there's a big difference here. There's a couple of big differences between STEMI and ischemic stroke when it comes to how we need to think about them as EMS providers. So first of all, the ability to diagnose what's going on pre-hospitally. For STEMI, it's not very, very different than diagnosis in the hospital. You need a 12-lead EKG, and as long as you've got some good eyes and a good brain to interpret that 12-lead EKG, your ability to make the diagnosis in the pre-hospital setting is essentially the same as my ability to make that diagnosis in the hospital. Stroke, on the other hand, is a much tougher nut to crack when it comes to diagnosis. Even for a guy like this, Dr. House. In the hospital, when I'm working in the ER in the ivory tower and patients come in and stroke is on the differential, it's really tough in a lot of cases to make an accurate diagnosis because there's so many stroke mimics out there. And so many of these patients have pre-existing limitations to movement or speech, and you got to sort out what's new, what's old. It's very challenging. And ultimately, no matter who you are, you can't make a definitive diagnosis of ischemic stroke as opposed to, say, head bleed without having a head CT scanner. And obviously, CT scanners are very rare. They do exist, but they're very rare in the pre-hospital setting. So another big difference between STEMI and ischemic stroke is the capability of small emergency departments to treat them. So at the top there, we've got a rural freestanding emergency department. And at the bottom, we've got UC Medical Center where I work. Obviously a big difference. So UC Medical Center does percutaneous coronary intervention. We are a comprehensive stroke center, and we can do 24 hours a day endovascular therapy for large vessel occlusion strokes. And as you would imagine, those therapies are not available at the freestanding rural emergency department. However, that freestanding rural emergency department does offer a pretty good therapy for most strokes. They've got a CT scanner and they've got TPA so that they can do intravenous thrombolysis. So that's a lot more of an opportunity to make a difference for a patient than what you have for STEMI. STEMI patients really, at least in the United States in 2020, need direct percutaneous coronary intervention in the vast, vast majority of cases. And obviously, if you're not a PCI capable hospital, then you're not offering STEMI patients very much. All right, so let's talk about strokes for a minute. What evidence is there for helicopter EMS to impact rural patient outcomes in ischemic stroke? As far as I'm aware, there's really only one study that specifically looks at this question. And it was published way back in 2003 by Silliman. And this was in the Jacksonville, Florida area. And basically they described what happened when over 3 years, 111 patients were flown from scenes by helicopter EMS to the Ivory Tower in Jacksonville for ischemic stroke or suspected ischemic stroke. And the author's conclusions on this paper was that helicopter EMS is really making a big difference in terms of improving patients' outcomes in ischemic stroke. Maybe. If you really delve into the numbers, what they really showed is that out of those 111 patients, 18 of them, which is only 16% of those patients, actually ended up getting thrombolytic therapy once they got to the receiving hospital, which means the other 84% of patients did not get TPA and really, therefore, probably had the same outcome as they would have had if they had gone by ground. Why didn't those patients get TPA? Well, a lot of them were stroke mimics. They didn't turn out to be true ischemic strokes. Some of them, I'm sure, were head bleeds. Some of them were true ischemic strokes, but their NIH stroke scale was too low to indicate thrombolytic therapy, or they presented outside the treatment window. So what I took away from this study, and what rings true in my own experience doing scene strokes as a helicopter EMS flight doc, is that most of these patients don't end up getting TPA. And that's worth knowing because there's a lot of people out there that are advocating that if you're even thinking about stroke in the rural setting, just call the helicopter, the patient will always do better. And I don't think that's really quite the truth. So, large vessel occlusion, LVO strokes. Endovascular therapy has really changed the game in the last 5 years. And this is something that we gotta understand because it used to be that the only treatment that was available was IV TPA, and IV TPA in most places in America could be done equally well at small, even freestanding emergency departments as it could at Ivory Towers. But now we've got endovascular therapy, also known as embolectomy, also known as neurointervention, also known as going to the angio suite, whatever you want to call it. We have a drain snake now that we have really good evidence, at least 5 studies that have shown improved outcomes in large vessel occlusion or LVO strokes. ESCAPE was published in New England Journal 2015, showed not only significantly improved functional status at 90 days, it actually showed that it cut mortality essentially in half at 90 days, 10% versus 19%, when you randomized patients to either get just standard IV TPA or IV TPA plus embolectomy. So the evidence is really solid for neurointerventional therapy at this point for LVO strokes. So we need some sort, in the EMS setting, some sort of an LVO screening tool. And there are right now a bunch of them out there. There's CSTAT, RACE, LAMS, FAST-ED. There's one called VAN. And I'm sure in the past 5 minutes that I've been talking here, one of you has probably developed a new one. There's a bunch of them. There's not a clear winner, shall we say, at this point for LVO screens. So what's really important here is that you and your department and your system choose one. We shouldn't be choosing which one we're going to use on the individual level. This should be a system decision where everybody is using the same LVO screen and using it in the same way. Here in Cincinnati, we do like CSTAT, the C in CSTAT is Cincinnati. So obviously that's something that we had a role in developing here. But there's not a clear right answer here. The only wrong answer is not to be using an LVO screen. And basically what these screens are doing is essentially what I call the My 11-Year-Old Kid diagnostic test. So this is Charlie. She's my 11-year-old daughter, or actually she's 14 now. This is when she was 11. And essentially these LVO screening tools are the sort of test that if my 11-year-old kid knows it's a stroke because it's that obvious, we're probably dealing with an LVO. That's kind of what you want to ask yourself ultimately. Is it such an obvious stroke that my kid would recognize that this patient's having a stroke? Then you're probably dealing with an LVO. So what should we be doing in terms of where to take LVO patients or suspected LVO patients? So this is the Mission Lifeline algorithm, the most recent version that I could find. However, I have been told by my fellow stroke experts that it's already a little bit out of date. So do we suspect LVO based on whatever screening tool that we're going to use? If yes, then we ask ourselves, was the last known well, LKW is last known well time, less than 6 hours ago? If yes to that, then we got to ask ourselves, what is the difference in the time it would take us to go to the closest hospital with a CT scanner and TPA versus the time it would take us to go to a comprehensive stroke center that can offer interventional therapy? What is the difference between those times? So on this algorithm, it says, is it 15 minutes? My understanding is that they have updated this to be 30 minutes now, and that makes sense to me. So if that difference is more than 30 minutes, if it's less than 30 minutes, then we ask ourselves, will transport to the comprehensive stroke center that can do intervention preclude the use of IV TPA? Meaning, are we going to get there further out than 4.5 hours from last known well time? And if yes to that, then, sorry, this gets quite confusing, obviously. Ultimately, if you can get them to a comprehensive stroke center in less than 6 hours and ideally less than 4.5, you're better off going straight to the comprehensive stroke center. That's what this algorithm is trying to show. And I think they make it unnecessarily complex. So last known well time. So let's say I went to bed last night at 10 o'clock, I was fine. And then I woke up at 6 this morning and my right side didn't work. Is my last known well time 6 a.m. when I woke up this morning? No, it's 10 p.m. last night when I went to bed. Most of the time frame for stroke is based on last known well time. Onset is not the same as last known well time. In the example I just gave, my onset was 10 p.m. last night when I went to bed. Sorry, my onset was 6 a.m. this morning when I woke up. That's when I first noticed the symptoms. But my last known well time was 10 p.m. last night when I went to bed. We need to know both. But I think what a lot of us are doing in the pre-hospital setting is just asking the patient or the witness, when did the symptoms start? And using that, whatever they say, as both onset and last known well time. And we need to understand the difference, and we need to know both. Can I get a witness? So very often when I get called for a scene stroke, There is a pre-designated LZ in the district of the fire department that called us. And I get there, the patient's there, I get the EMS report, but the person who witnessed the last known well time and what's different with Mrs. Smith today versus yesterday, that witness is not there. And Mrs. Smith, my patient, very often because of dysarthria or aphasia, can't tell me. And so if I don't have a crystal clear report from the paramedics that are on the scene, then Mrs. Smith may ultimately not get therapy that she would benefit from, because giving somebody IV TPA or doing neurointerventional therapy is a high risk situation. And stroke doctors don't like to do it unless they are really sure that patients fall within the given timeframes. So whenever possible, if you are taking a stroke patient to the hospital or you are rendezvousing with helicopter EMS with a stroke patient, get the witness. And that witness may be a family member, it may be the DirecTV installation guy, whoever it was that can tell us more about what happened and when. Get the witness there to increase the certainty with which people can make decisions about treatment. We are lucky enough to have a helicopter that's big enough that we can fly that witness with us. A lot of helicopter EMS systems are not, but regardless, the helicopter EMS crew that you're going to rendezvous with would appreciate the ability to talk to the witness when Mrs. Smith can't tell us that much very often. A couple other EMS stroke pearls. I don't want to step on my friend, Dr. Chris Richards, who's going to talk about stroke this afternoon, so I'll go through these quickly. If possible, getting a 20 gauge in the right anacube specifically is helpful for these patients, because most of them are going to get not only a non-contrast head CT, but a CT angiogram. And the CT angiogram is best obtained by giving the contrast through at least a 20 gauge in the right arm. If you can't get it, you can't get it, not a big deal, but that's ideal. When you're taking the patient to the hospital, whether we're talking about a primary stroke center, a rural freestanding ER, or a comprehensive stroke center, please call ahead, see if you can set up straight to CT, because that can save a lot of time. Ischemic strokes rarely need intubation. And when ischemic strokes get intubated unnecessarily, it makes decisions hard for stroke doctors, because obviously when somebody's intubated, they can't talk to you. They're usually sedated to the point where it's tough to get a good neuro exam. So if we can keep them safely unintubated so that we can get a good neuro exam, it makes decision-making more clear for stroke doctors. That being said, if somebody clearly is failing to oxygenate or failing to ventilate, or aspirating because they can't protect their airway, we do what we got to do. But if you're on the fence, I would lean toward not intubating if you think you're dealing with an ischemic stroke. All right, let's switch gears for just a few minutes and talk about STEMI. This is obviously a big inferior ST elevation MI. Inferiors are typically right coronary artery lesions and very prone to both bradycardia and very preload dependent in a lot of cases, so prone to hypotension when we give therapies like nitroglycerin. So for STEMI, as we mentioned a few minutes ago, pre-hospital diagnosis is pretty much equal to in-hospital diagnosis, as long as you've got the capability to do a 12-lead EKG and you've got the training to interpret a 12-lead EKG. And unfortunately, I don't have time to talk about pearls about diagnosing STEMIs today. That's not the objective of this talk. Now, I hear other flight programs sometimes encouraging EMS to give them a call for scenes if you've got a sweaty guy with a good story for chest pain, even if they don't have a STEMI on 12-lead. And I personally think that's pretty irresponsible. Obviously, if a guy's got a good story for chest pain and he's sweaty, we're worried about him. We're all worried about him, no question. But if he doesn't have a definitive STEMI on 12-lead EKG, I don't feel like it's responsible for us to be spooling up an aircraft. That's a very expensive proposition. There is risk involved. And it's going to take that aircraft out of the rotation to be able to respond to a trauma patient or a stroke patient or a true STEMI patient that would really benefit from them. So don't be calling helicopters for sweaty guys with good stories if they don't have STEMI on 12-lead. Similarly, no longer is left bundle branch block, even known new left bundle branch block, good enough to activate a STEMI activation. Most of those do not turn out to be true coronary occlusions. Some of them are. And if you are extremely well schooled in Scarbosa criteria and Smith criteria, more power to you. If you know a patient meets Scarbosa and Smith criteria and you want to activate STEMI based on that, cool. But not just for any run-of-the-mill left bundle branch block. So, since the time of Hippocrates, we are going to review all of the literature about helicopter EMS scene response for STEMI. Don't worry, it won't take long. There's one study to my knowledge, and we actually published it. So in 2012, this was in Academic Emergency Medicine. And what we did was we took a look at about 40 inter-hospital STEMI transfers from non-PCI EDs to PCI-capable EDs. And for all 40 of those patients, they had all called 911 for the initial response. So we simply did geomapping and looked at what would have happened if EMS had called helicopter EMS from the scene instead of transporting the patient to the non-PCI-capable emergency department. And what we found was there would have been significant time savings in terms of first medical contact to balloon time, about 30 minutes, in fact. So if you know you're dealing with a STEMI, we ought to be going to an ED with PCI capability, if at all possible. And now this recommendation is going to vary based on what part of the United States you're in. But I think in most of rural America, a good rule of thumb would be if it's going to take you more than 40 to 45 minutes to get to the PCI capable hospital by ground, then considering helicopter EMS would make sense because most of the time there is going to be a time savings there. Now, you know the logistics and the geography in your system much better than I do. So this, you may need to vary that recommendation based on where you live. We're almost done. Quick word about cardiac arrest with return of spontaneous circulation. So if you are lucky enough through great skill, great knowledge, and ACLS to obtain ROSC on an adult cardiac arrest patient in the rural setting, I think it would make sense to consider helicopter EMS rendezvous at the local hospital. I don't want you waiting on scene for a helicopter because if the patient rearrests, you're on your own. So I think it makes sense to start moving toward the closest hospital. But once you get there, if the patient's actually doing pretty well because of your post-arrest care, and the helicopter is only a few minutes out, it may make sense for you actually to stay outside, rendezvous with the helicopter at the local hospital, and do it as a scene rendezvous at the hospital. Because once that patient goes into that hospital, EMTALA is triggered and there's a big time sink effect there. And that patient ultimately would probably benefit from going to a PCI capable hospital that can do targeted temperature management. So something to consider. I don't have literature behind this recommendation, but it does make sense and it's something that works well in the Cincinnati region. All right, so quick review. Most scene strokes historically don't actually get TPA. I think a lot of people don't realize that. In that Silliman study, only 16% did. And I think that's because a lot of helicopter EMS programs kind of oversell the difference that a helicopter can make for a scene stroke response. So when you're on the fence and a patient doesn't meet your LVO criteria, whichever LVO screen you're using, I don't think it makes sense to call a helicopter to a scene. I think it makes sense to go to the closest hospital that has a CT scanner and TPA therapy. LVO strokes, we have essentially unequivocal evidence at this point that they do better with endovascular therapy. Now, in what time frame is still a little bit in flux. The answer there may ultimately be 24 hours, but I think for EMS purposes and making decisions about whether or not we should be going straight to a primary stroke center versus a comprehensive stroke center, I think in the under 6 hour window is the time when it's really important for us to try to get them directly to a comprehensive stroke center that can do interventional therapy. And if you've got the positive LVO screen and you can get them to that comprehensive stroke center in less than 6 hours, then based on your local geography, I think it's reasonable to consider HEMS. Now, obviously, helicopter EMS is not always going to be available, either because they're on another flight or because of weather, but it's worth considering in those patients. Onset is not the same as last known well time. We need to understand the difference, and we need to know both for these patients. And if at all possible, if you can get a witness to the hospital that the patient is going to, or at least to the rendezvous point with helicopter EMS so the HEMS crew can talk to them, that can be the difference between getting either IV TPA or neurointerventional therapy and not. We talked about the 20 gauge and the right AC. We talked about straight to CT scan and STEMI. Sweaty guys with good stories, but no STEMI. Don't need a helicopter. In general, left bundle branch blocks don't need a helicopter. But if you know you're dealing with a STEMI, it does make sense, at least in most areas of America, to bypass non-PCI hospitals in favor of going directly to a hospital with a cath lab. If it's going to take you more than 45 minutes or so to get to that PCI capable hospital, I would advocate for considering helicopter EMS, but what that time frame is going to vary somewhat based on your local geography and your local system. In status post cardiac arrest with ROSC, it's at least worth considering HEMS rendezvous at the local emergency department, but I would not recommend waiting on scene in the middle of nowhere for a helicopter because that patient may rearrest and leave you on your own. So that's what I got. What we're doing right now is really tough. Nothing flows. It's hot. We're wearing PPE. We get out of breath because our work is really physical. And my daughter, Charlie, who I showed on that earlier slide, drew this picture for me, and I wanted to share it with you guys. Respect to all of you for what you're doing and gratitude. And if we got any time, I'm happy to try to address your questions.
Thank you, Dr. Hinckley. If you have any specific questions, please put them in the Q&A section. They're hard to filter out. It's like a sea of messages in the chat section. So that'll help us know what questions you want to ask. We do have a question from Dan. He said, or he asked, does that mean EMS shouldn't over triage strokes and time does not always matter? Last I heard, TPA was being used less frequently and the push was for interventional radiologists to go in and remove the obstruction.
Okay, so first of all, if a patient is within the IV TPA window, which in most places is considered to be 4.5 hours from last known well time, even if they are also a candidate for endovascular therapy, most places are still going ahead and doing the IV TPA therapy prior to going to the angio suite and doing the embolectomy. So that's worth understanding that it's, if you're going to get embolectomy, but you're also a candidate for IV TPA, then in most places, you're going to get the IV TPA as well prior to going to the angio suite. So what was the second part of that question, Floyd?
1 second, I was on another question. Apologize for the dogs. He said, last I hear, TPA was being used less frequently and the push was for interventional radiologists to go in and remove the obstruction.
Yeah, so I think that's the best way I can answer that question. You're right. There is a big push. If we're dealing with a large vessel occlusion stroke, to get them to the interventional suite, but that does not preclude them from also getting IV TPA prior to that, if they're within that 4.5 hour window and they don't have a TPA contraindication.
All right, I think I'll give you one more and then we'll have to let the next speaker get ready because we're cutting into their time a little. But you can feel free to go in and answer in the chat menu or the Q&A. But one last question was, any thoughts on mobile stroke units? Is this going to continue to be a thing or have we gotten over this?
Tell you what, I think that's a wonderful question. There is a speaker this afternoon, Dr. Chris Richards, a friend of mine from here at UC, who has 1,000 times the expertise on mobile stroke units that I do. So why don't we re-ask that question to Chris this afternoon? I think he's definitely more qualified than me to answer it.
All right. Well, thank you, Dr. Hinckley. It was a phenomenal presentation.